Hello everyone. So today I'm gonna discuss the tragic event of Kristian Eriksson's collapse and the possible causes that he might have suffered from. So here is a list of the differential diagnoses of the possibilities that could possibly be in Eriksson's heart. Some of the differentials are far away from Ericsson. Some of them are very possible. So let's go through them one by one. We have the first one. So the first one is hypertrophic cardiomyopathy. This one. Hypertrophic cardiomyopathy, it could be happening in athletes. It's a disease in which the heart muscle becomes abnormally thick. We call it in medicine hypertrophied. The thickened heart muscle can make it harder for the heart to pump blood. So it obstructs the outflow of the heart, of the left ventricle, and it becomes life-threatening. It could obstruct the aortic valve. So it's one of the possible causes, although it's could be excluded because most of the athletic people get tested, especially highly professional athletes like Ericsson. They get tested from time to time, echo to their heart to see if there's any abnormality, health checks for the team, especially it's a national team competition, so it's on a very high level. They don't want these events to happen, but it's still a possibility. Still a possibility. Let's go to the arithmogenic right ventricular cardiomyopathy. The arithmogenic right ventricular cardiomyopathy is a disorder of the heart. In this disease, fatty fibrous tissue replaces normal heart muscle. This in turn interrupts normal electrical signals in the heart and may cause irregular and potentially life-threatening heart rhythms. I think if they've done MRI to his heart previously, I mean, not now, it's possible they could have detected that abnormality, especially if fatty tissues replace the cardiac muscle. It's very clear by the MRI. The other one is dilated cardiomyopathy. So dilated cardiomyopathy is also a disorder of the heart. The heart gets dilated, the cardiac chambers become very dilated, abnormally dilated. So the heart muscle becomes stretched and thin. This means that it's unable to pump blood around your body efficiently. Inherited dilated cardiomyopathy is caused by change or mutation in one or more of the genes. So it's also less likely. It's less likely. It becomes manifested younger than this age. I mean, especially it could be manifested in his age, but very unlikely. He will suffer from heart failure very earlier than this event. So it's might be not the possibility, not common. Also, the arithmogenic, well, arithmogenic could be a possibility, yeah. But the dilated cardiomyopathy is, I think, it's far from reach. Other cardiomyopathies like left ventricular non-compaction, this also causes earlier problems, like chronic problems, not starting suddenly, like it's over time, develops over time. So it's easily detectable by cardiac MRI of the heart. So it's not a possibility really in this case. So the other cause, congenital anomalies of coronary origin and course. It could be manifested later in life, but at this age, well, I doubt it because this is not the first time his heart is exposed to stress of games. So this is not the maximum of the stress his heart gets. Aortopathy like Marfan syndrome, ascending aortic aneurysm. He's obviously not Marfanoid. So Marfanoid people are very tall with thin, slender limbs and slender and long fingers and toes. Descending aortic aneurysm is usually associated with Marfan syndrome, so it's not a possibility here. Besides, it's treated surgically. If the patient is not treated, he will die in a matter of a couple of hours, maybe. Valvular heart disease is another possibility, like congenital aortic stenosis, mitral valve prolapse. This is excluded because he's been playing football for 20 years or so. These are the causes in general of sudden cardiac death in athletes and non-athletes. So this section usually, and in all age group, young, old, but this one is most likely in athletic people. So the acquired causes now of the sudden cardiac death, like atherosclerotic coronary heart disease, this is extremely unlikely because he is not old. This is usually in elderly people in their 40s, 50s, 60s. Kawasaki disease. Kawasaki disease is usually affects children, so it's not a consideration here. Myocarditis could be a possibility. Could be a possibility that leads to arrhythmia, cardiac arrhythmia. But Kristian Eriksson didn't have any signs and symptoms. He didn't have any flu, any shortness of breath, any pain in his heart. So it's very unlikely, especially in terms of COVID-19. So patients who have symptoms, especially flu, chest pain, shortness of breath, cough, they usually get tested and have rest, and because of the possibility of COVID. So it's very, very extremely unlikely in Ericsson. Let's go to the other side and see the structurally normal heart, the possibilities of the differentials during which the heart is normal, not like the congenital and the genetic causes. These are more likely to occur in Kristian Eriksson. So structurally normal heart, such as one of the causes is congenital long Cutie syndrome. Congenital long Cutie syndrome is a hereditary cardiac disease characterized by a prolongation of the QT interval. We have in the heart we have like the ECG, T wave, QRS, and then T wave. So he has congenital long QT. Is a prolongation of this segment, becomes very, very much longer. You cannot really exclude it, the congenital long QT syndrome. Congenital long QT syndrome, it's arithmogenic disorder. It can cause sudden cardiac death. The age of presentation is most likely 14 years old, but the age of death, the age that this disorder most likely causes death, is 32 years old. So it is a high possibility that Kristian Eriksson has congenital long QT syndrome. Right? It could cause also something called Torsades-de-Boîte, which is a polymorphic VT. VT is a ventricular fibrillation that requires DC, oxygen, medications, and other stuff done to Kristian Eriksson. So let's go to the next disorder. It's catecholinergic. Let's clean the window. Catecholinergic polymorphic ventricular tachycardia. So this long name is a rare condition. It causes an irregular heart rhythm that can be life-threatening. It often shows up in childhood usually, but can show up later in life also. The first sign is often fainting or near fainting during exercise or strong emotion. So although it's most likely manifested in childhood, but it could be a cause, but less likely than congenital long QT. We have another very important possibility. It's Wolff-Parkinson-White syndrome or other accessory pathway disorder. So this could be like summarized as an extra electrical pathway that causes a rapid heartbeat in the heart. It's present usually at birth. An abnormal gene is the cause of this Wolff-Parkinson-White syndrome. It's also associated with some other congenital abnormalities, which is less likely in Kristian Eriksson's heart. why is it a strong possibility and why is it important? It's present since birth. Yes, the extra pathway is present since birth, but patients most likely experience symptoms between the ages of 30 and 40 years old. So that's a very strong possibility here. Another strong possibility is a Prograda Syndrome. Prograda Syndrome is a rare inherited heart condition that disrupts the flow of sodium or potassium ions into your heart cells. It causes disruption to the electrical impulses which keep your heart beating. So it can lead to a very fast, life-threatening heart rhythms like VT or VF. It could lead to death also. Symptoms are also fainting during exercise, dizziness, gasping, irregular heartbeats or palpitations. Let's see the age of presentation. It's usually, it may affect individuals, the Prograda syndrome affects individuals at any age, but it usually affects middle-aged men around the age of 40 years. The disorder was recently described in the literature, so but it's still a very strong possibility. So if you see this section is very strong possibility. Okay, so this is these are, let's say, congenital causes of arrhythmia in athletic people. Here we have the acquired causes. The acquired causes of arithmogenic disorders that are not present with birth. The first one is commotio cordis. So this phenomenon is a disorder in which a sudden blunt impact to the chest causes sudden death in the absence of cardiac damage. This condition is a long history. There are many stories accompanying this commotio mortis. So it's usually associated with chest trauma. So this is a less likely possibility because, to be honest, I didn't notice that Eriksen had any accident or had any trauma to his chest during the match, during the first half of the match. So when he collapsed, nobody was around him. He was alone. Another possibility. So this one is not a possibility here, or less likely possibility. He might have a chest trauma during his exercise. So still a possibility. Other acquired long QT syndrome. It could be drug-induced. So acquired long QT syndrome describes pathologic excessive prolongation of the QT interval. As we said, we have P, Q, R, S, and T. So prolongation of this segment, it becomes longer because of the drugs. It could be like a result of environmental stressors. So it could be reversed back once the drug is stopped. We don't know any history of Eriksen doesn't take any medication recently. If he is taking medications for his heart, like his doctors would say, because this is an important thing, because there's a strong possibility of collapse during the match. So this is not a possibility here. The rumors saying that Eriksen was drinking an energy drink before the match, but when I have seen his account, that was belonging to 20 days ago. So besides, I don't think the team doctor allows him to drink like an extra concentration of caffeinated drinks, energy drinks. So could be a possibility, but it depends. Well, actually, it depends. We need to take history from Eriksen. We need history. We need to do examination to his body and heart. We need to do investigations like ECG, cardiac MRI, many other investigations. Echocardiography is also an important investigation. There are many investigations that need to be performed to Kristian Eriksson. And also we should exclude the possibility of myocardial infarction, because this is a very important cause. Although he's an athletic and his heart is most likely healthy, but any of these causes can cause myocardial infarction from, let's say, coronary spasm or the discontinuation of the blood flow to his heart. So this is all of these investigations must be performed to Kristian Eriksson before saying what is the most likely diagnosis. I'm just making hypothetical differentials of what could have happened to Kristian's heart. I've also made a number of notes also. I've made a number of notes about Kristian Eriksson's heart. So it says I've collected them from the literature, from the textbooks, from the research papers, and at least less than 35 years old. So cardiovascular causes of sudden cardiac death include hypertrophic cardiomyopathy. We have discussed this. Arithmogenic right ventricular cardiomyopathy. We have also discussed this. Abnormalities of coronary arteries, congenital, acquired, Kawasaki disease, we have excluded this. Endocarditis, myocarditis, we've discussed this, and it could be a cause, but unlikely in terms of COVID. If he gets flu, he has to be excluded, prevented from having the match. Pericarditis is a possibility. Dilated cardiomyopathy is less likely. Aortic rupture, as you said, this needs an urgent surgery, and until now, nobody said he had surgery. Besides, he's not morphonoid. Correctation of the aorta, very unlikely. Valvular heart disease is also very unlikely, as they do health checks when he went to Tottenham, when he went to Inter Milan. So this is very unlikely. Pre-excitation syndromes, which are the channelopathies, like Wolff-Parkinson-White syndrome, we have discussed this. This is still a possibility. Conduction diseases like Morbus 2. This is types of heart block. Second degree, third degree heart block. This is usually congenital and manifested earlier in life, like in teenage or childhood. Ion channelopathies like catechol, cholinergic, polymorphic, ventricular tachycardia, Prograda Syndrome. We have discussed this. Congenital or acquired long Cutie syndrome. We have discussed this. Perioperative is around surgery, like if he has done surgery to his heart. This is absolutely not included here, and he didn't have any surgery recently. Hypertrophic cardiomyopathies, and another note, non-compaction, this was excluded. It needs, it manifests slowly and earlier in his life. Athlete's heart is cardiomyopathy, hypertrophic, because of the overactivity of the heart. So all of these causes I've mentioned, all of them cause ventricular fibrillation or ventricular tachycardia, and that's why the team doctor performed DC, oxygen, and other medications like adrenaline to save his heart. So that's why DC, it could have had VT or VF. So that's why they shocked him. This is still a possibility. We don't know. We should have someone talking to the people and saying what has happened, because the report has to be in details. As I'm just talking about theories here, because I'm not part of the team. Okay, so let's go to the other notes. Hypertrophic cardiomyopathies, again, same notes here, same notes. Commotio cordis. Undiagnosed. Well, this is also mentioned before. Hypertrophic cardiomyopathy. I've mentioned that in the table, the previous table, in the photo, in the image. So sudden cardiac phase. So as I told you previously, these causes all lead to arrhythmia, like ventricular tachycardia VT, or we call them VT, and VF. All are possibilities, because all are the end result of all of the other causes. All of them lead to these two. It could lead to like sudden cardiac arrest, like the ECG is just flat, not VT, not VF. But as long as they've given him DC, because they have shocked him with DC, it's very, very likely that he had VT or VF. So that's why they gave him the DC. Another table here, table of causes, differentials. Ischemic heart disease like myocardial infarction has to be excluded by the ECG. Coronary spasm from medications, calcium abnormalities could be a cause. We call it Prinzmetal angina. Inherited channelopathies, long QT discussed, short QT syndrome. It's all the opposite of long QT, could be a possibility. Prograda Syndrome was discussed. Repolarization syndrome, also one of the channelopathies. But this is very, very rare. Catechol and Allergic, Polymorphic, VT. We said it shows up in childhood, so it's unlikely. Cardiomyopathies like alcoholic cardiomyopathy is to dilated cardiomyopathy, and it's less likely here. Hypertrophic possibility. Idiopathic obesity is obviously not obese. Fibrotic, this comes gradually, not suddenly. Arithmogenic right ventricular cardiomyopathy was discussed. Myocarditis, we discussed it. Heart failure, this is very unlikely here because he is absolutely normal before the match and the period before the match. Valve disease, aortic stenosis, very unlikely except if he has the hypertrophic or obstructive cardiomyopathy, which I don't know. I feel it's like unlikely because they do health checks to the team. They would, it would, if they have done echocardiography or MRI, it would scream to them like, I am hypertrophic cardiomyopathy, so obstructive cardiomyopathy. So I just exclude this because they do the health checks. Tetralogy of Fallot is a congenital heart disease, very unlikely. It's manifested in childhood and not applicable here. So this is the differential that I've made for the Kristian Eriksson's collapse. The differentials and the possibilities of his collapse are those that you see, that the ones that I've discussed in this video. I wish speed recovery for Kristian Eriksson. I've seen this guy in 2019 when Man City played against Tottenham in the Champions League, when they won Man City despite they lost in the Etihad Stadium. He's very polite, very calm boy, very calm man. He's very, very polite. Very respectful man. I wish him speedy recovery, and I'm sure he is strong enough, and he will come back as soon as possible. I'm sure he will play again. Let's hope and pray for him to come back very soon. Thank you for watching, and goodbye.